You can hear?
Yes, Dr. Anu, please just hold for a while. So now you can see the preview screen. Okay, Dr. Anu, you can start now.
Great, thank you so much. It's my honor to present at this neonatology conference on the hot topics of neonatal medicine. I really enjoyed the previous discussion today on translational bioinformatics. I am actually not a neonatologist, but I am a pediatrician, and I work with little tiny babies just after they're born as well. And I'd like to talk to you today about reimagining treatment for pediatric clubfoot, and it's a project which we affectionately call Baby Steps. My name is Anuradha Dayal. I'm a pediatric hospitalist and an orthopedic hospitalist at Children's National Medical Center in Washington, D.C. I'm also assistant professor of pediatrics at George Washington University School of Medicine. Okay. There we go. And before I start, I wanted to thank the people of Abu Dhabi. They gave a really generous gift to Children's National in honor of His Highness Sheikh Zayed, through which my research has benefited. And this research builds on his vision to improve the health of children around the world. So thank you very much for making this vital work possible. So I'd like to talk to you about pediatric clubfoot. It's a three-dimensional deformity of the foot, which appears, at birth. It happens in utero for reasons that we don't know. And what happens is, as you can see in this picture here, the baby's foot is, instead of being straight like this, it is turned inward and upward. It's actually the most common skeletal deformity in children, and it has an incidence of 1 to 2 per 1,000 births. So the biomechanics of clubfoot, it's actually very interesting. So there's a problem with tendons, and then there's also a problem with the bones of the ankle and the foot. So some tendons in the foot are longer than normal, and some of them are shorter than normal. And that is what causes this upturning in a three-dimensional way. As you can see here, this is a very severe case of babies who are born with clubfoot. And as you can imagine, if it's not treated, they don't grow out of it. And these babies turn into toddlers, the toddlers turn into adults, and they end up walking on the outer edge of their foot, which is really sad. And if it's untreated in a lot of places, these children are marginalized around the world. So this is more, just more details on how we categorize the clubfoot. We talk about it in 5 different components. So one is the equinus deformity. The foot is pointing downward instead of at a 90 degrees. One of this is the varus component, where you can see the back of the leg and the ankle are not in the same direction. This is adductus, so the heel and the toes are not aligned. This is cavus. So as you can see here, the big toe is curled inward, and it's actually not in the same plane as the pinky toe. And then you have an element of derotation, where you can see, instead of the foot being straight, it's actually rotated in many different severities along the axis. And it's interesting because it is the most common skeletal deformity. And as I was doing my research, I learned that the Egyptians actually painted pictures of babies or even adults on the walls of the pyramid. And then the father of medicine, which is Hippocrates, the Hippocratic Oath, he actually wrote about a pediatric clubfoot and his treatment for it back in 400 BC. So the incident, as I mentioned, is 1 to 2 per 1,000 births. And so worldwide, it's about 250,000 new cases each year. And over 1 million children have not been treated, and they can't walk properly, and is the leading cause of physical disability in the world. There is a predominance in males, about a 2-to-1 ratio, and this is consistent across all ethnic groups. 80% of these are isolated birth defects, which means that there's nothing else wrong with the child. There's no other orthopedic problems, there's no heart problems, there's no lung problems. It's really isolated, and there's also no intellectual problems. And it has an idiopathic etiology. They've been a lot of gene research into it, but they haven't isolated anything yet. And sometimes 25% of the times there is a family history. And so again, you know, this is what these children look like. If they're not treated, they grow up into adulthood like this. And I think the biggest thing for me is that this can be treated and these children can grow into whatever they want. So this is a picture of Christy Yamaguchi. She's, you know, the very famous ice skater from the United States, an Olympic medal, I forget which Olympics, but she was actually born with bilateral clubfoot, so both her feet. And she was treated early in infancy. And the reason actually she started figure skating was to strengthen her legs. And then she became an Olympic ice skater. So I think that's pretty remarkable. So the current standard of care to treat clubfoot is actually called the Ponseti method. And it was developed by a surgeon in Iowa, Dr. Ponseti. And what he realized is that they used to do surgery for this, and doing surgery in a little baby, it really leads to a lot of scarring and problems later on. And so what he realized is that you can actually serial cast these infants. So what they do, as you can see here, it can take anywhere from 4 to 6 weeks, sometimes 7 or 8 weeks, depending how severe it is. Every week they apply a long leg cast all the way from the groin to the toes. And the orthopedic surgeon, in a very specific way, manipulates the club foot and turns it outwards and actually overcorrects it during the course of the treatment. So every week the baby comes in, they put on a new cast, they come back the next week, they take off the cast, manipulate the foot again, and so on and so forth. And using this method, it's actually 95% successful, which is amazing. So the question is, what is the problem and why am I interested in this research? So there's actually a lot of problems, or I should say difficulties with this method currently. Physician specificity, the process, and then the main ones are really access to care and medical education. So physician specificity, this isn't a normal cast that you can go to your emergency room or a general practice physician or the ER to get placed on the baby. It actually takes a lot of training and expertise by pediatric orthopedic surgeons who see many of these cases. And if it is attempted to be applied by someone who isn't as well-versed in the training, you can actually worsen the deformity, which can lead to non-correction or need for surgery later on. In the United States, I'm sure as everywhere else, pediatric orthopedic surgeons are very talented, but there are not as many of them as we would like. In Washington, DC, we're surrounded by 4 states, and we have parents who drive to DC, you know, sometimes multiple hours, 3 to 4 hours a day for a one-way trip to an appointment, and then they drive home another 3 hours until the next week. And this is only exacerbated around the world where the distance is much larger. You know, babies with leg casts. So basically for 2 months while your baby's having this treatment, you can't bathe them from the waist down because they have plaster casts. As you know, you can't get plaster wet. Otherwise, especially with a baby's skin, it's very sensitive. It can lead to skin ulcers. Babies have, you know, their diapers, there's a lot of overflow. You don't want to get that on the cast as well. And then as we've seen in COVID-19, a lot of the Ponseti clinics have closed. And so parents are unable to either start their baby's treatment at ideally less than 2 months old, or they've had to interrupt their treatment. And then we use a cast saw to take off the cast, and you know, it makes a loud sound, but also pediatric skin is very sensitive and occasionally you can have cast saw burns. But this is the biggest problem with the Ponseti method right now. It's all over the United States. In Europe, they use a similar method, but a little different. But since 85% of the kids who are born with clubfoot are actually in low and middle income countries, there's no access to this care. And so they're growing up without any treatment. And then fourth, there's a component of difficulties in medical education. So as you can see, it is a 3-dimensional deformity, but as we describe it and as we describe how flexible the foot is, we're actually scoring it on 2 dimensions, as you can see here. And reality, as we've seen, it's a 3-dimensional correction, and there isn't a way to predict how long the treatment will be or how responsive the child will be to treatment. And there's also no imaging used. So there's no x-rays. If you take an x-ray of a baby's foot, their bones aren't ossified yet. We're not going to use CTs in little infants for radiation, and then MRIs are also very expensive and very bulky. So overall, the treatment of Ponseti method is very effective, but it's also very subjective. Orthopedic surgeons have a very trained method to do it, but it's very artisanal. It's very hard to teach. There's no images to share. There are no data libraries or data catalogs. And it really doesn't adequately talk about how the foot is changing in 3 dimensions. So the question is how we can make this better. The Ponseti method was introduced in the 1960s, and that was the same year that we landed on the moon. And there haven't been any advancements in that. And now we're in 2020 and we have 3D imaging and computer modeling that really can be leveraged to improve data sharing in medical education. So I've been reading a lot about biodesign statements. So this is going to be my biodesign statement for this problem. So what we're doing is we're looking for a way to measure the complex 3-dimensional movements in serial clubfoot casting for infants less than 2 months old with a diagnosis of clubfoot in order to quantify the correction process and improve healthcare delivery. So in the current state, the baby comes in, we kind of eyeball it, we look at it, we score it in 2 dimensions, and then the orthopedic surgeon, does their treatment. But we'd love to reimagine the care of how we're going to do this. And what we like is a future state where you can actually introduce imaging. So what if we could obtain a 3D image of the deformity and then use computer modeling to predict all the different next steps and stages and use that to help democratize healthcare. So this is our team who's working on this. I'm the pediatrics lead. I'm working with the chief of orthopedic surgery at Children's, Dr. Achin, Dr. Cleary, who's a scientific director at Children's, and Dr. Monferretti, who's our biomechanical engineer and computer vision expert. So we're trying to develop a precise and accurate method to quantitatively measure the 3-dimensional angles and spatial differences in serial clubfoot casts, and also simulate transformations in computer models. So we approach this with 3 different steps. One, we're trying to analyze the clubfoot in 3 dimensions. 2, we're trying to manipulate what would happen to the clubfoot during the treatment process. And then we're also trying to simulate a model and make it so it's precise and accurate and clinically equivalent to what an orthopedic surgeon would do. So this is some examples of what we've been working on. We have a very high volume Ponseti trained orthopedic surgeons, and we see a high volume of clubfoot patients. So we've been analyzing them and saving their casts through their Ponseti treatment, and then also noting what their DiMiglio score is here, so we know how flexible the foot is, so we can kind of determine what the different treatment process and treatment paths are for each patient. So this is a video of one single patient going through the casting technique. And as you can see, all the casts are overlined on top of each other. And the thigh and the shin part, that stays the same, but if you look at the bottom, you can see the foot moving. And so this is an example of the trajectory that we've been analyzing in 3 dimensions. And then we introduced computer modeling. So this is some rubber clubfoot models that are used for training. And what we did is we 3D scanned them and we tried to manipulate them to move in the direction for correction. So here are some examples of what it looks like. This is the before here in the dark, and then you can see where the foot has moved. And this is representing what the treatment path is for the infants. And this is some animations here. You can see we are correcting the equinus, so lifting the foot up here. Here we're correcting the rotation of the foot. And then here you can see we're correcting the varus angle of the foot. And this is all with maintaining the structural integrity of the surrounding foot and leg. And this is an animation. We took a patient's casting series and we animated it to see what all the different changes would be. So this is the same cast in 3 different views, and you can see what the direction of correction is here. So I wanted to talk about a small subset of results. So this is a subset of 9 patients who've had an isolated diagnosis of clubfoot, 6 males, 3 females, 2 to 1, just like we were talking about. 5 of them had unilateral clubfoot and 4 of them had bilateral clubfoot. So altogether, we collected 49 casts from them. All of these patients were less than 2 months old at treatment, and they all had an average Dimiglio score of 14, which is about a severe to a moderate problem. So what we did, we took a 3D scan of their first cast that they had, and then we also scanned their last cast. So we know what the first one and the last one look like. So based on all our models and all our patient data, we wanted to figure out, okay, if we showed this to a computer, can we make what the last model will look like? Can we predict that? And what will that look like? And so this is one of our results. So here visually you can see that it's pretty accurate. We overall did a pretty good job in keeping the structural integrity of the rest of the leg and the foot, and the final foot position is in the same. And we were able to do this for every sub-step up until this one. So visually it looked great, but we also wanted to measure the angle. So this is a small subset of the simulations that we did for all these patients. And what we can see is when we measure the angle of Aquinas, we were able to match it to the real cast within 1 degree. And then the same thing when we were measuring the derotation, the correction of the derotation of the foot, when we compared the real cast to our simulated cast, we were able to match it within 1 degree. And then finally, we also wanted to look at the point clouds. What a point cloud is, it's almost like the atoms of a 3-dimensional model. And the green one is actually the point cloud of the real cast, the real last cast. And then we overlay that with our simulated cast, which is in purple. And as you can see here, it actually overlaid very nicely. So what this shows us is that there's very high accuracy on our simulated models compared to what the orthopedic surgeon would place themselves. And we're able, these point clouds, the difference in the spatial differences is within 2 millimeters. As you can see here. So we've developed a reliable method to measure the complex 3-dimensional movements between serial clubfoot casts. And hopefully with this ability to calculate this, we will be able to generate computer models that can predict the optimal cast shape. And then no matter where you are in the world, somebody can 3D scan the original deformity, and hopefully we can help figure out how to get that child the treatment and the standard of care that they need. That's it. Thank you.
Push holding slide.
Wala si Sid.